So hi, everybody. Thank you so much for being here. Today we have two directors and the founder of Pink Concussions who will be introducing those speaking on the panel. Just for some background information, Pink Concussions is a nonprofit for female brain injury caused by sports, domestic violence and assault, accidents, or military service. So Cara Ferber is the Advocacy and Policy Director of Pink Concussions, very much dedicated to the missions of the nonprofit. As a spokeswoman and lobbyist, Cara attended the Congressional Brain Injury Awareness Day in DC to advocate and educate about gender-based disparity in medical research, access to healthcare, and policy design. She's given many presentations and interviews at medical conferences and recently was honored by the Brain Injury Association of New York State and received the 2020 Victory Award. So Catherine Snedeker is a therapist, researcher, brain injury professional, brain injury survivor, parent of a child with a brain injury, and on top of all of that, executive director and founder of Pink Concussions. She's working to develop sex and gender appropriate evidence-based research approaches on identification, management, and support of women and girls with brain injuries. So Catherine conducts some research studies, facilitates ongoing support groups, and has also produced 7 international summits on female brain injury, and presented on a few of these things. So thank you both so much for being here. I'm excited to meet the panelists. If you would introduce them. And I'm excited to learn more. Thank you so much.
Thank you for having us today. And I'm going to pass the honors to Cara to introduce.
Okay, well, thank you for a very nice introduction and for having us today. Our first presenter is Dr. Maheen Massouf Adamson. She is Clinical Associate Professor of Neurosurgery, affiliated with Stanford School of Medicine, and the Clinical Research Director of Rehabilitation Services at the VA in Palo Alto. Adamson completed her undergraduate degree in neurobiology and women's studies at the University of California, Irvine. She completed her PhD in neuroscience from the University of Southern California and a postdoctoral fellowship in psychiatry and behavioral sciences at Stanford School of Medicine. Dr. Adamson's expertise and interests span employing translational neuroscience methodologies for diagnostic and neuromodulation treatments, such as repetitive TMS, for frequent health problems in patients with traumatic brain injury, psychiatric problems, and Alzheimer's disease. She has employed advanced structural and functional imaging modalities and biomarker assessments in veteran, active military, and civilian populations with these health problems. She has been a leader in identifying gender differences in brain injury, particularly in the veteran population. She currently serves as PI and site PI on numerous neuromodulation clinical trials and collaborates internationally for developing advanced diagnostic methods in neuroimaging, especially in underserved communities. In her position at the VA in Palo Alto, she is actively involved in translating research, such as non-invasive brain stimulation and other therapies. Her latest efforts are deep phenotyping patients with post-acute sequelae of COVID virus with blood and brain biomarkers affecting their cognition and quality of life. Dr. Adamson has authored numerous peer-reviewed publications on the cognitive and neural basis of Alzheimer's disease and on a wide range of topics in TBI. She has received recognition in national and international settings. Her goal is to incorporate advanced treatment and diagnostics tailored to each patient's needs into a standard of care to improve their daily functioning, reintegration into society, and long-term rehabilitation. Thank you very much for joining us. And Maheen, please go ahead with your presentation.
Thank you very much for a wonderful introduction. And let me just share my slides before I start talking. Let's see, share and. Can you guys see it?
Yes.
Yeah, perfect.
Yes, ma'am.
Okay, well, thank you very much for the introduction. And Cara, I am indebted to you for keeping in touch with me and getting me involved in this. I've been very hard to get a hold of these days. There's a lot happening on the COVID-19 front lots of talks, lots of publications, and definitely a lot of grants that are going on. So I've been incredibly difficult to reach, and I am very, very excited that I was able to give this talk. And I signed up early. So kudos to all the organization and all the wonderful outreach that you guys do. It's amazing. So today I'm not going to be talking about some of the work that I'm currently doing, which is COVID related or older adults related or minority related. All of that encompasses females differences compared to males. Today, I'm going to be talking about particularly sex differences in neuromodulation treatment approaches for traumatic brain injury. So I'm going to show you some specific, I'm going to talk a little bit about the sex differences in brain injury, particularly in the military and veteran population. I'm going to set the stage trying to describe some of the epidemiological differences that we see in the military population in terms of symptom reporting and in terms of what the characteristics look like between male and female. Then I'm going to talk to you a little bit about why do I talk about neuromodulation, as Kara so nicely illustrated. I've got about one completed and 3 clinical trials going on in which I use brain stimulation to treat different problems that veterans face. And some of those problems have to do with cognitive disabilities, depression, pain, PTSD. And in doing so, one of the things that we realized, and because of my extensive collaborations with people who do sex differences research, as well as the pink concussion outreach with Catherine, I wanted to look at what is going on in neuromodulation treatments with respect to the differences between men and women. So I'll talk a little bit about that. Then I'll talk to you about results from a review that was published on sex differences in neuromodulation treatments in brain injury. And I spoke earlier on a webinar at Pink Concussion about these results, but now it's going to be on a PowerPoint slide. So you guys can see a little bit more about what we discovered in this review. And we have some future recommendations as well. So the problem that we have is within the military and within the veteran population, we have these centers that were at the VA that were created that are called polytrauma centers. Polytrauma means, you have various injuries. So you can be amputated, you can have spinal cord injury, and you can have a traumatic brain injury. So the center is, polytrauma means that, lots of different types of injuries occur together. Within the veteran population, what we found is that women represent very, very small numbers in the general polytrauma patient cohort. And of course, it's related to the fact that, there's less women in the military than men. But they are increasing, and you probably have seen a lot of data, and I've written about it before, that the number of women in the military is increasing, which means the number of women in the VA, in the veteran population, is also increasing. But their experience is not wholly represented in the published outcomes, and that inform data-driven decisions that regard their treatment, which is what we're going to talk about, that leads to management and care of the polytrauma population. So in the old days, I used to think of everything as a hierarchy, and it's not. Everything is a circle. So it's policy-driven to data-driven, and then data-driven again informs policy to make changes. And that circle is broken at certain points, and there's lots of different gaps that we as researchers, especially women researchers, are trying to fix. So what are these gaps, and how have we identified them? This is a review that was published 3 years ago. Gosh, 3 years ago already, 2018. So we did it in neurosurgical focus, and this was a traumatic brain injury among female veterans, and this was a review of sex differences in military neurosurgery. So on the field, on the ground, and then in the veteran population. So this is one of our papers that I just mentioned, that we found that the representation of women is not, it's not wholly done. Around about 10 years ago and maybe 5 years ago, there was a lot of push from NIH as well as DoD and VA that was very specific to women based on very similar studies like mine. So they actually came out with all these different mission statements that you must pay attention to whether outcomes of traumatic brain injury depend on severity, injuries, sex, and ethnicity. I'm not going to use the word gender in this talk, and if I do, disregard it. I should only be saying sex at this point because I'm really very focused on the difference between the biological differences that are seen based on sex between men and women. They also looked at examine issues related to women's circumstances and stressors. So we should be looking at workplace sexual harassment and assault, PTSD, pre-military trauma. We should definitely, this is what DoD and VA recommended, is you should oversample female populations because they're not represented and you need to really address what's happening with them. And again, coming full circle, as they themselves are saying this, and then they're saying it again at the bottom, that you must develop policy to eliminate MST due to association with poor readjustment when returning home. So really, really trying to get at what the gaps are and how do we identify them, do something about them, and then change the policy. So lots of papers were coming out. This is older studies that came out, and lots of different studies in the military and the veteran, but there was a lot more data needed because none of these actually served the purpose of giving us a picture of what was happening with the women in the military. So within our sample, within our VA Palo Alto polytrauma sample, we did a cross-sectional investigation. And the way we did it was we looked at chronic symptoms in a cohort of men and women post-injury. But we did it in a particular way. So this was published in 2020, early 2020. We did a matched analysis of TBI patients, 49 women and 49 men. Not a huge sample, but we can't do that because we had smaller number of women, plus we wanted to match them. So when we matched them on three things: age at admission, the time from injury to admission, and the mechanism of injury. So we did three different, so our main goal was if we match them, any other difference that comes out is going to be based on our hypotheses, the difference between men and women. The outcome domains we evaluated was the neurobehavioral symptoms and reintegration indices. So we looked at living situation. Do women live more alone than men? Are they more homeless? Are they more employed versus unemployed? And what we found was this is something that has been reported by other people. We found differences between male and female, men and women, in vestibular and in cognitive. So this was published in 2020. We did composite scores from the NSI, and we actually saw that women had more reports, self-report symptoms of vestibular dysfunction, and they also had some cognitive self-report that was worse than in women than in men. That has a lot of implication as the population ages, right? So if you can identify women have more cognitive issues, then that's something that we should be paying attention to as the population is aging. So women reported significantly increased vestibular system, women reported significantly increased cognitive symptoms. Other NSI did not reach significance, and it was consistent with our results in the overall cohort. So in terms of living situation, the female gender was the only significant predictor variable of increased likelihood of living alone after controlling for NSI domains in education. The women were more likely to live alone than men. Homelessness was not included in the living alone variable but only 4 women were homeless in the sample. So we can't comment on the homelessness. And in this paper, we didn't find anything on the employment status, but again, our sample was small. So summary of results is, this is what we found. It was statistically significant. It was published. So this is what the cohort looks like. This is what the characteristics of the cohort are. When we include them in treatment studies, what does this mean? Do we just give them treatment just like every other treatment and not worry about all these factors? Well, here are some of the facts that we already know based on some biological mechanisms as well as what happens in treatments. Women experience worse post-TBI outcomes than men. We just mentioned that in a few things that we found in our own cohort. And it's due to sex differences in metabolism. Is it because of our biological composition of how we process molecules? Is it because of certain things certain areas in the brain that are activated more or have greater thickness of the brain? Or is it because of what's called social determinants of health? Is it because of our social factors? Is it just because maybe there's a socioeconomic status difference? There's an education difference. Males overrepresent traumatic brain injury related research due to traumatic brain injury population makeup of veterans and research design and recruitment, which is what we're going to talk about. Neuromodulation is a term that we use for brain stimulation, and that I'm going to use that term throughout. And that is a type of a treatment that we use for rehabilitation and brain injury. And it's growing in popularity because it's non-invasive. There are some FDA safety regulations you have to follow. But as you can see with recent FDA approvals of this brain stimulation for obsessive compulsive disorder and major depression, little is known about sex differences. So we have this cohort, we know these differences exist. We're applying treatments in brain injury without knowing without applying any of those sex differences in the treatment trials. So we're going to switch now to what neuromodulation is, what brain stimulation is, and how we can incorporate these things that we know about sex differences in treatment trials. So what exactly is the brain stimulation paradigms that I study? I study transcranial magnetic stimulation, which is TMS. I don't study but have written about deep brain stimulation, and I don't study but have written about transcranial electrical stimulation. Transcranial electrical stimulation is more invasive. Deep brain stimulation is obviously the most invasive, and transcranial magnetic stimulation is not as such. So we can define those like this: different types of neuromodulation. So we have deep brain stimulation where you actually go inside the brain. So it is invasive, yes. There's also vagus nerve stimulation, which is where you stimulate the yellow nerve that you see on the screen, and it is moderately invasive. RTMS is not invasive, and it is a magnet, the actual magnet that you see on top of the head that stimulates on top of the skull, and I'll explain what that is. It is not invasive. And then there's transcranial transcranial direct current stimulation, which is, I think it's not invasive, but it does pass current through your skull as opposed to a magnetic wave. So these are the different types of neuromodulation treatments. I want to go back to something really quickly. And this is something that I have presented to other audiences before. I want you to think of treatment not in the same way as you think of medication, but just remember, treatment is an outside mechanical thing that you're doing with brain stimulation, right? You have a device and you're putting it on the head, and for magnetic stimulation or electrical stimulation. For deep brain, you're actually going inside the brain. You're passing electricity, you're passing magnetic stimulation into the brain. You're not taking any medication. So you're not physically actually changing the molecular structure of the brain. Through electrical stimulation and magnetic stimulation, you are going to cause plasticity in the brain, but you're not taking any meds. If you were taking any meds, there are huge differences between how medications are processed between men and women. We already kind of know that. So this is actually a really cool article that I read a long time ago, and I'd like taking this out. Prescription painkillers, men overdose more often because when they take it, the metabolism is faster, so it goes away faster, so they take more of it. And women, they take less of it, find more relief, but they have a harder time with addiction because it stays in their system longer. It has to do with the acidity in our stomach, our metabolism. Antidepressants, some are more potent for women, less acidic stomach, more absorption, interaction with other drugs. Tricyclics are better in men. Sleep aids, liver breakdown is faster in men than in women. Anti-anxiety, stomach absorption, liver breakdown, it's more of a potent effect. Antipsychotics, liver enzymes work at different speeds in men than in women, which might affect how the body responds to antidepressant, anxiety, painkillers, and other drugs. So this is, when you're trying to do something with treatment, you gotta know this in your head, that there are differences that exist already in medication. And you know that their differences exist from the data and self-report of symptoms. So now when we go into something like this, we go with this added understanding that the men and women are going to respond differently to this neuromodulation. But as opposed to medication, what does this actually do to your brain? So neuromodulation, this is how it looked in 1911. This is how it looks now. So this is progress in science, right? I love this picture. I think it's open in the back. I mean, the guy must be able to breathe, right? So you've got this thing on your head, you're stimulating the whole head, and now we're doing precise location using MRI. And I put my picture there because I didn't want to ask anyone permission. So I give myself permission to put my picture there. So this is all based on MRI, based on where you're stimulating. So it's very exact, it's beautiful, and it's awesome, like very progressive. In terms of you look at what was happening in 1911. But what does it actually do? Does it do anything similar to what medications do? Well, imagine yourself, I'm sure some of you have been inside an MRI scanner. MRI scanners have a lot of, they basically are 3 times, if you're in a 3 Tesla, they're 3T, that means 3,000 times more than the Earth's magnetic field. So you're lying in there and your particular cells in the brain are being aligned with the Earth's magnetic field. It's a very strong magnet. So what happens with this 8-shaped coil that you see here is that it's an electromagnet. Electromagnet is basically a nail, and you wrap a coil around it, and there's current flowing in it. So it's an electromagnet. It's a powerful magnet. What it does is that in a very fast manner, it actually stimulates your brain on top of the skull. And when it does that, it creates on top of the skull a magnetic strength as much as an MRI magnet that you can get into. That magnetic strength that is created on top of the skull actually penetrates the skull and goes into your brain and basically makes the neurons talk in the synaptic cleft to the neurons, and they're able to talk to each other. So you are able to induce what's called plasticity through the release of neurotransmitters using this technique. So you are changing the brain, right? You're not giving them medication, but you're changing the brain. So we hope in a good way, because it stimulates the firing of nerve cells and release of neurotransmitters. So it's brain-derived neurotrophic factor, and you're changing certain aspects of the brain. So you're like, okay, well, that's wonderful. So we're causing a change. What does that mean for the sex differences? So we did a review, and this was done by my former postdoc, Angela Phillips, and another student, Saurabh Sami, and myself. And I had this idea about 1.5 years ago, and it's really nice that we were able to do this review, because I really wanted to know if anybody's looking at this. So sex differences, as we've already gone through, we've already gone through the medication, the endocrine function, cortical thickness in the brain, so social determinants and health. We know that it disproportionately represents male, the TBI-related research. We think that sex differences in TBI-related research are already sparingly reported. So going down further into treatment, specifically for neuromodulation, which is being applied heavily now, they're going to be less reported. So what is our objective? Our objective was to use the scoping review framework to identify the types of evidence, key characteristics, and knowledge gaps. We want to summarize the reporting of sex and gender in the current literature of neuromodulation, because it was reported both ways. We wanted to update the TBI community on the evidence across the current brain stimulation methods, and provide research, policy, and practice recommendations. So we did this huge analysis, and we were able to follow the, preferred reporting items for systematic reviews and meta-analysis extension for scoping reviews. It's called PRISMA. And we were able to do this over 5 electronic databases, and we got articles ranging from 2001 to 2020. All these brain stimulation techniques are kind of new, so we didn't want to go to 1950s. But otherwise, we will be including articles with that guy with the thing on his head. So broad preliminary research of 3 brain stimulation methods. We looked at the 3 that we talked about: RTMS, deep brain stimulation, as well as the transcranial direct current stimulation. When we did this, we wanted to recognize the interchangeable use of sex and gender in many studies, sex found in studies focusing on biological factors, with gender focusing on psychosocial factors. We conducted the search on February 12th of 2020. We performed screening performed in an unblinded, standardized manner by 2 reviewers, and then disagreements resolved by a 3rd reviewer, which is me, because I sat there, I'm like, no, fix this, fix this. We did the search strategy, identify a total of 572 records with 51 duplicate entries that we removed. And then we looked at trial protocols, commentaries, abstracts, and records without full texts were excluded. This is how we actually charted it out. And what we found that out of 572 studies identified, 54 studies were included because they matched our criteria. And only 7 report and discuss sex and gender differences. 7 out of 54. So there were obviously more male subjects than females, despite a general rise of female participant inclusion. So even though we conducted this a year ago, guys, this is like 2020, and this is only 7 were reported. And when we say they were so most of the time what happens is you have a table 1 and you have demographics and you say, this is how many males, this is how many females. And then after that, it's like done. Nobody reports anything further. So we looked specifically at the fact that is anyone actually talking about the difference, or if there is any, or if there is any, are they providing recommendations to how this treatment can be done in females? And if they're not providing recommendations in how it can be done, then are they actually really saying this in the limitations? Because, you know, when you write a paper and you know your own limitations that, okay, do this in people over 65, males, you know, blah, blah, blah. None of them were actually, they don't even think it's a limitation. I mean, it's hilarious to me, right? I mean, it could be any other data point. So only 7 reported, only 7 discuss it, and then none of them think that it's a limitation. So even if you don't have the data and you don't report it, you should at least say in the limitation that, yes, we couldn't do this. We need more women, we need more outreach, we need, so that's the kind of gap that we're trying to identify. It's really important now to do this, because what we do with our studies is we look at multiple data sources. We look at brain structure and function, look at demographics, we look at biomarkers that are usually from blood, we look at cognitive and neuropsychology, we look at functional measures, how you are doing in your life, quality of life, all kinds of self-report measures. When you have so much data, you have to be able to characterize it by one of the biggest divisions of humanity is men and women. I mean, that's one of, I mean, you have income data, education data, SES, so you have to be able to do it. So if you don't do it, you should at least say it in limitations. So what we found is there's a lack of reporting creates a knowledge gap. Yes, menstrual cycle could also be correlated with cortical excitability of RTMS. So why are there differences? One of the differences we've talked about is the biological processing of certain medication, could be social determinants of health, but also when you're doing this in women who are of childbearing age and even after menopause, because after menopause or during menopause, your hormonal changes can actually lead to different rates of excitability in the neurons, which you are modulating with a brain stimulation device. So you should be able to just do a simple blood test with a woman saying what luteal phase of the cycle they're in, you know, what phase of the cycle they're in, or, you know, maybe at the basic level, ask them the question about when was their last menstrual period. Integrating treatments into existing observational cohort may grow female population sites. So there's a traumatic brain injury has several big longitudinal studies going on, and there's a lot of data available. So, and I've spoken, and I think many people are thinking about doing this or already have been doing it, is to spin off treatment studies from those big cohorts. I think it's very important to include these variables in those treatment studies because you have the data from observational studies. Now, if you're going to launch them into treatment, stuff like this has to be addressed. Otherwise, you're going to be not getting good response to the treatments you're getting you're doing because you have not assessed the variability and done precise targeting from the start. Emphasizing collecting standard set of female-specific factors in TBI evaluation, yes. We've talked about specific things, and I'm preaching to the choir when it comes to traumatic brain injury evaluations. There's a lot of guidelines that are available, and people have been working very hard on them. So the recommendations we have is clinical recommendations of creating a standard of practice to assess sex differences as it is relevant to TBI, considering personal biases when offering treatment, and educating providers on recent neuromodulation findings to welcome women into these settings. Research recommendations to increase female recruitment strategies consider sex differences in analysis, plan a priori, and sample match by sex and age. There's more women caregivers than men. When you're recruiting, you have to have strategies in the recruitment plan to say, okay, we can provide you travel. We can figure out who can take care of your father or your husband or whoever you're taking care of. Maybe they're a stroke patient, maybe they have Alzheimer's. There's all kinds of strategies you have to think about if you want to enroll women in your sample, because women are the bigger caregiver force. Policy recommendations of strengthening guidelines to include analysis of sex and gender and not mere inclusion, as well as study design sufficient for valid gender analysis. Oversample women, write about it in your discussion, write about it in your limitations section. These should be policies. Like I would, and as a reviewer, if I see a paper and they're not doing it, I'm like, please correct this. This is a resubmission. We cannot accept it the way it is. So, and that has happened to me before. So these are some of the neuromodulation updates that were given to us when DVBIC was also part of VA Palo Alto. We have about 3 funded neuromodulation trials. I also represent the research that's happening at the Headache Center for Excellence. And we also have an RTMS protocol. We also have a robotic arm that we just purchased, and it is located at the VA Livermore, and that provides precise targeting of the TMS system on a human head with reduced provider and patient contact. And you don't have to constantly try to locate that area in the brain because it's robotic and it can do it by itself. And that's about it. And this is my thank you to everyone. And I hope I didn't go over too much of the time. Can everyone hear me?
That was awesome.
Thank you.
Thank you very much, Maheen. You are brilliant. And I really appreciate that you shared all that information with us. Lynn Becker, she has pursued a career of 20 years in clinical research trial design. She created and implemented the Power of Patients platform to engage, inform, and educate individuals who experienced concussions and traumatic brain injury. Power of Patients provides tools and guidance to tell the personal story, track symptoms, learn about medical research, and participate in clinical trials. This is the first successful initiative to facilitate research participation and effective collaboration between individuals with neurologic disorders and the research community. It is strategically designed and tailored to help those with traumatic brain injuries and their caregivers. Lynn acquired critical knowledge through her own challenging experience as the mother of 2 daughters who each survived distinct brain traumas. Her leadership and advocacy made it possible for her daughters to navigate the complex journey to access care and rehabilitation. Power of Patients is a transparent platform with a dashboard for each individual to track symptoms precipitated by the injury and learn about clinical trial research. Additionally, the website provides resources for caregivers and families for strategic prevention, medical treatment, therapeutic management, and TBI support. Currently, Power of Patients is partnering with the National Institute of Neurological Disorders and Stroke and submitting information about health and research needs for people with multiple neurological disorders. Lynn is making a significant impact towards the goal of direct clinical trial research for TBI by empowering patients and educating researchers that if you have seen one brain injury, then you have experienced only one brain injury. No 2 brain injuries are alike. Thank you very much, Lynn, for being here today and working with Pink Concussions.
Thank you, Cara. That was a beautiful introduction. And welcome, everybody. I'm going to share my screen now. And let me put it into presenting mode, please, and minimize this. All right, and is everybody able to see the screen? We're good to go. All right, awesome. Let me scoot this down. As Cara said, I am Lynn Becker, CEO and founder of Power of Patients. I myself am a biostatistician and epidemiologist. I've spent well over 20 years in the clinical trial industry, designing them, managing, and recruiting for pretty much every kind of therapeutic. It was nice because I got to develop best practices and not just focus on one specific therapeutic area. As she also said, Cara also said, I became a subject matter expert in traumatic brain injuries after I had to become the full-time caregiver, first for my youngest daughter and then my oldest daughter. And I also was recruited to run and manage the NICO, which is NICO. It is the TBI portal for the special ops team for the US government. After I went back to work, after my daughter finally made some progress, I was managing the DVBIC databases that Mahim also mentioned as well, and saw some really interesting outcomes with the NICO treatment that I'll give some input on as well. So I did not choose TBI, TBI chose me. So with that, let me go down to my next screen. I don't know why it's not, there we go. Hang on one second. First of all, what is Power of Patients? So Power of Patients is an app. It's a web-based app, and it is all patient-centric. And as Cara also said, no two brain injuries are alike. And the tagline for our company is, it's your health, your data, your terms. And everything is customized to each and every patient. So our mission is to empower patients as well as caregivers. We have a track for them too. And while they're managing their rehab, sharing this information with their doctors, but we want to accelerate the clinical trial research in this area as well. So the goals for this webinar, this class, is to describe the dashboard, examine some of the literature specific to the female data, and discuss our findings. And I will let you all know that this is the first time anyone is looking at the raw data, which is really, really exciting. So before we go any further, we did product launch after several rounds of beta testing. Product launch was done in October of 2020, and now we have 370 patients on board in less than 4 months. So it's pretty exciting what we are able to collect so far. So the story behind Power of Patients, just really briefly, I started the company just a little over a year ago. And as I have already told you, I myself became the full-time caregiver, mostly for my youngest daughter, as well as my oldest daughter. And I was able to fast track her rehab therapy, which was really, I mean, a blessing in disguise, I guess you could say. And with my youngest, her case was such an anomaly. It's been published in papers and so on. But I really thought I was alone, because at the time when she was injured, I was searching for all sorts of information and clinical trials and everything. And I was honestly left with just being told, it's just a concussion, just relax. When in reality, her optic nerve was torn, she had dysautonomia, every part of her body was neurologically broken, and she stroked after her injury. So it wasn't just a concussion, and she does have permanent brain damage as well. So being told one thing, but you're looking and seeing something else really was a disconnect for me. So it obviously became very clear, and everybody knows this, there is a huge knowledge gap in brain injury, not just care, but research. And again, that's where we are focusing. So with that being said, let's move on to what we are. It is patient-centric, personalized, it's real world, it is longitudinal, and we also provide education to our users. So what is reported versus what is collected. And also, as Mahim mentioned, it was really difficult to find data that's out there so that we could do a comparative. So it's not a lot out there, but what I did find, which we will reference throughout this report, in the Brain Injury Association report on their website, they listed some gender research that was being done. A lot of it was being done in Canada, and these were the takeaways. They talked about hospitalizations, work-related brain injury versus sports-related brain injury, and then life after brain injury. So that was what, and that was the same theme over and over again, and the references are cited below. What we are collecting on our dashboard is we have our basic demographics. We also look at injury pathways, and we use both structured and unstructured data, which is really important with our AI algorithms. Then we look at what the person's current symptoms are, then their top symptoms that they themselves choose to track. And if a symptom is not reported, they are allowed to create a new symptom. So every dashboard is personalized. And then I have always done SDOH, social determinants of health research in my career, because it has always been very important. And so with NINS, National Institute of Neurological Disorders and Stroke, when we did that request for them, the amount of new determinants that came out is basically now anything outside the doctor's office. That is the high level category. So this is a really important find. And it's also a really important acknowledgement by the government, because they're recognizing that it's not a social determinant health. A trigger is not just related to your zip code or to your SES. So you'll see some interesting data here as well. So in the literature of that BIAA report that I'm referencing, they had almost an equal distribution, 45% females, 55% males. Age was not reported on that distribution. But what we have in our database, we currently have 72% females are reporting data, and 28% of our users are males. As you can see the breakdown, so I color coded it to make it a little bit easy, so we could focus on the pink. Our age ranges are really close when we break them both out. As you can see, the maximum, we both have two 81-year-olds. We have a slightly younger female population down to 14, but the average age for both of them hover between 45 to 49. In the literature, we do not have any reports that I could find that was indicating how they were being reported. So first of all, we're going to talk about the types of people that we have. We have 60% of our patients are TBI people. Some of them are chronic, some of them are acute. I did not break the data up for this presentation. 21% are categorized as other, and I'll get back to that in a second, and 19% are caregivers. And to Kara's point as well, the majority of our caregivers are women too, which is a really interesting thing, that you have to really look at how a caregiver is impacted by being a brain injury caregiver. The 21% is really great, because now we have other neurological conditions getting on board. We have stroke survivors, we now have Parkinson's people, and we actually have some clinicians that are, and therapists that are, they themselves are TBI persons. So I just wanted to point this out. This is for anybody. What's interesting about our stroke survivors is, so because this was designed with TBI in mind, there's a huge overlap with all neurological conditions, and we're mapping on the back end side. But and also because my daughter did stroke, so I knew that I needed to build that part out as well. But what's interesting, we have one of the rarest stroke cases in the world. There is only one of two cases called Eagle syndrome, and she is one of our biggest advocates with using the dashboard. And she has been able to really empower herself with her neurologist in what she has found through the triggers that she's been tracking. So really quick, men, they report that they have 52% of them have a current TBI, and 19% of them, sorry, hang on, there's an Air Force jet going over. 19% are, they also have a TBI, but they're not an existing patient. And that's a big difference between an acute versus a chronic person. And then the 29% are other. And that is also made up of stroke people, not caregivers, but also stroke and Parkinson's. All right, so when we look at our next one, in the literature, they were reporting for their injury data that women were sustaining more concussions than men in similar sports. We do not differentiate by the kind of sport people are injured by, which we can. But again, we built this dashboard out to be more robust. But what's interesting is that both men and women do report accidents. Oh my goodness. Accidents as their leading cause for their injury. Women then report falls, followed by collision, and assault to me is very concerning, and then sports. And if you look at the male categories, you have the accidents, and then it's sports, and then it's falls, collision, and then stroke. So this is a really interesting find because most literature that you see will indicate that there's a lot of sports injuries when indeed there really isn't. One of our features that we have, just to speak quickly about type of injury, as we are testing out our algorithm data, people are asked to give us the story behind their injury, which is very important. And the story behind their injury is how were they injured? And we ask for signs at the time of their injury. We ask about their loss of consciousness, and we're going to get to those. But when they give it to us both in a narrative as well as in a structured format, this is where we start to test the AI algorithms because we can use audio data as well. But people miscategorize themselves. And I don't have the exact rate because we're still cleaning that data up. But by miscategorization, I'm going to give you a very clear example. One patient said that she had an accident, but the computer said false, she had a fall. And right now, because we're able to manage this and we do actual validations, visual validations, while we're looking at the new algorithms, we pulled it to see what did her narrative say. And in her narrative, she said, I was on my horse, I had no helmet, the horse got spooked, he took off, I fell and hit my head. And that is why the computer said false. It wasn't an accident, she had a fall. But when you take a moment and you think about the fall, her injury pathway was not that she just tripped and fell on the ground. She was on an accelerating horse without a helmet. And did she hit rock? Did she hit grass? Did she hit dirt? And did she hit one location of her head or multiple locations of her head? And this is where I do believe that we will find a lot of really interesting data as we start parsing the injury data out to these very specific elements. And this is going to be very important as we build out the buckets of our injury type data pathways. So I just want to explain that. So right now our AI algorithms are about 87% accurate. We don't release it until we're above 90% in terms of the best practices that we used to do always with the government. Loss of consciousness, I bring this up because it's a very, very important metric. We have 56% of the men and 44% of the women that reported loss of consciousness. And this again is very important because not only are you having trauma to your head, you now are losing blood flow and oxygen. And so what kind of impact or effect is that actually having on the long term, or how much therapy you should have? So these are questions nobody has any information on. And as you can see, the literature was not reporting anything that we could find. So we also went further. Here's the injury location that I talked about. The majority of people, if you can see here on the 57% for the females and the 46% of the males, were reporting other. And what they wrote down every time there was an other category, they didn't know because they had probably lost consciousness. So we need to link those pieces together. But when you remove that other piece right there, we start to look at the left side of the head for the females, the front of the head for the females, followed by the left side of the head. I don't know if you can see it right here. And in the males, it's also front of the head, but then they're hitting the back of the head. When you get down into these groups below, this is where people are reporting multiple locations. And again, this is very, very important because of the coup and the contra-coup indication that could be impacting the therapy that people should be receiving. Next we have is symptom data. Again, all we were able to find in that article was women experience longer and more symptoms than men. We do not know how long they are reporting these symptoms for. These are the symptoms that they are reporting right here, right now, that they are having trouble with. And then once they choose to track, they're able to track their top 3 initially, and then they add more as they feel comfortable with the dashboard. We try to baby step people through stages. But for the symptoms, we've got the majority of them are categorizing as other. And if you looked at our raw dashboard, this is because people were not able to find what category best described their symptom. So this is huge, this other. And I just want to take a pause for a second and let you know how I curated all of these intake forms. Because I worked for the universities. I've also worked in corporate, and I've worked in academic, or excuse me, as well as the government sectors. I knew where all of these forms were. So I went to the NIH, the PubMed, to the VA. I went to various university institutions, and I requested copies of the forms. I received them, and I cross-mapped all of these different form intakes so that I knew I wasn't going to miss. And so this is why it's really interesting, because we still are missing other kinds of categories for people to be able to just check the box on. So again, this is where our AI starts coming in, and we're able to discriminate and put them into some of these existing buckets of categories of headaches or stress or loss of balance. But this is where we then want to have the partners, where the patients and the doctors work together. Is, are you really having stress, or are you having anxiety, or is it really a family involvement? Because as people write these write these comments out for their new variables, the algorithm is finding 2 or more kinds of symptoms. So it's not for us to choose, that's for the provider to choose and how they're going to discuss it. And this is where we're hoping that it's going to increase, and it actually is increasing interaction with patients and doctors. When I move over to the hormone data, well, we do not have specific hormonal data. We do have people that do report menstrual cycle problems, and we have 4.5% of the patients say that they have more problems when they are on their menstrual cycle. SDOH data, again, the literature does not have a whole heck of a lot of information on SDOH. We can go out and we can grab some of the huge data sets for SES and zip codes and things like that, but this is different, right? So again, the others, this is where we have had, this is a huge find, 1,500 plus, or almost 25% of our reports about SDOH, which are triggers causing their symptoms to become exacerbated. We run this through our AI again, and we can boil it down to about, right now it was 52, but we also are working with some of the polytrauma units at the VA, the one at the Jamaica Plains, and there's an outpatient group in Orlando. And we received some more forms that will help us now boil these others down into a few more categories. So we got the 52 into 18, which is manageable, and it's probably, I would say, more believable. But again, we are just now starting to dive into the data. So this is where it's really, really exciting for us. But when we take the others out of the picture, stress is the big one. Loud noise is the big one. The access and the use of the phone, as well as the car. And it just keeps going on. And some of these triggers are clearly related to different kinds of therapies that could help them, whether it might be vestibular or neurooptometry. Again, it's for the doctor to determine, but they are reporting these problems. So let's dive a little bit further. We do break it down into travel, high-level domains. So on our dashboard, we have high-level domains for cognitive measures, vestibular, speech pathology, vision, etc. And we do the same for SDOH, because SDOH, which is the trigger data, and we're trying to teach patients as much as we can so that people with brain injuries, first, let me back up, as you may or may not know, but for the sake of being complete, people with brain injuries really truly have difficulty in explaining themselves. They may not be able to find the words. And I speak from experience with both of my daughters, as well as reading what patients are reporting. But the more we're able to help them categorize and show the data to the doctor, they become empowered. You should read some of the reports. It brings tears to my eyes with how much they're empowering themselves. So with that, we broke our trigger data down into travel, environmental, wellness, screen time. And then there's still that other category too. So in travel, car, and again, this is female, car is the #1 problem that women are having in terms of triggering their symptoms. So when we present their reports to them, they have a longitudinal timeline, not only of their symptom scores, because they track every single day. And by the way, our engagement rate is 76%. It's phenomenal. They track every day their scores. The intensity goes from 0 to 100. 0 is none, 100 is the absolute worst. And they then identify the triggers that day that they were just, involved with. Like, what did I encounter today in order to exacerbate or even get better my condition. And so we have little stopgaps when there are certain deltas to make sure that they tell us narratives, what's going on. So CAR, which kind of makes sense because you've got vestibular as well as vision issues going on. Loud noises for environmental. In the wellness, it's stress. And in the screen time, it's computer, and it's really close to phones as well. So when I sent this to Cara, which I guess was a couple of weeks ago, Cara, we now have, I just checked right before I logged on, we now have 370 patients and 76% engagement. And these are huge metrics. And the United States is almost completely covered. Our strength in the UK is getting very strong, as well as in Australia too. So, and this is on $0 for advertising. It is about how we speak to patients and the network effect and the word of mouth. And, you know, Cara, I'm sure, can express and explain more about that with what they do. Whoops, let me go back up one. So what we do, because I come from clinical trials, I also come as a caregiver. So I kind of straddle both sides of the fence, right? This is a bottoms up approach in order for us to address and serve these three constituencies. Patients need help, and we give them this free app. This free app, and there's a picture of the dashboard that they can share with their clinician. Now, it's not an app that you have to go purchase, by the way. It's just a web-enabled app, but you can use it on your phone as well. And because I know so much and know what we're supposed to do in terms of recruiting, I am very upfront with people. The only way this stays free for them is that I must use aggregated, de-identified data for research, for people to look at the data, researchers to look at the data, to develop hypotheses, to develop clinical trials, as well as bring them into clinical trials too. So, and we're actually doing a clinical trial summit on Wednesday where we're bringing in 3 of our sponsors so they can just have a one-on-one talk to the sponsor. So people love our webinars, which is great too. So what is the message? The message here is there is a lack of focus on sex and gender, which reduces the rigor of research design. It reduces the generalizability of study findings, and that reduces the effectiveness of clinical implementation and knowledge dissemination and practices. And that is the hard truth. The study that Mahim did cite, this huge TBI track study, it is all based in university settings. And that is predominantly white men with insurance. So even that population, as robust in terms of locations of where it may be, it still is slightly slanted. So there really has to be a bigger voice or a bigger movement. And that's what I'm really trying to address here, is to bring these people together. And with all my public health work, there are very good success stories of making a change from the bottom up. And the message is to make sure you take care of your patients. And that's all I have. Any questions? Oh, I stopped right at 4 o'clock too. I'll stop screen sharing.
I see a
Yes.
couple of questions in the chat, and then if somebody wants to speak out, but I'm just not sure if we still have time to do this.
Okay.
Just in case we're out of time, I do want to thank Columbia. I want to thank Lynn and Mahim both for their lovely presentations today. And it's great to see you guys. And thank you, Cara. Do we have more time for Q&A, or do we need to shift to the next room?
I think that a different room is speaking, but thank you guys all so much for coming here. Thank you, Dr. Adamson and Lynn, for speaking. That was so informative and so interesting to learn about. Thanks, everybody. And yeah, you can stick around for the next meeting if you'd like to.
And I added my email if you'd like to email me questions, and I can forward to Mahim and Lynn as well. My email is Cara, CARA@pinkconcussions.org.
Right.
Perfect. I was going to ask you to do that, to just go ahead and filter